to team
invite
one,
the
sir.
first teams.
First team from Saftarjung Hospital. Your first spotter, I would like to request Malti ma'am and Venkateshwaran sir to read the questions.
Okay, shall I start?
Yes,
Yes.
ma'am.
Yeah.
It's team one, right?
Yes, sir.
Now let me know what is the diagnosis in this case. Your diagnosis. Am I audible?
Yes, ma'am. Yes,
Yes,
ma'am.
very clear.
There appears to be a full thickness burn over the face and scalp, ma'am, with underlying eye injury as well.
It's scalp defect and exposed
With the
scalp
scalp.
area, ma'am. With on the hand, there is also a full thickness burn on the left hand, ma'am, at the base of the thumb with exposed underlying structure.
Probably electric burns, ma'am.
Dr. Bhattacharya, can you?
Yes.
Yeah.
Yes, ma'am.
Can you speak about the case?
Madam, you have to ask questions completely about this case to this team for 15 minutes.
Okay.
No other, you two panelists only will ask.
Yeah. So, what is your plan for this patient? You think it's an electric burn? Did you tell me that? Yeah.
Yes, ma'am. Yes, ma'am.
High tension electric. Okay.
Yes, ma'am.
So, what is your plan?
So as soon as we receive the patient in an acute stage, we assess the patient, the airway, breathing, circulation, the normal trauma protocol. And as soon as the
No,
assessment...
you have received the patient, right? The patient is before you.
Yes, ma'am. So we assess the patient and we start the resuscitation, ma'am.
Yeah.
We look for the other associated injuries as well.
Because specific and confined to that case, not associated.
We have to
means
get
it
a-
will
we have
pass
to
on
get
to
a-
other team.
We have to
Be
get a
specific.
ECG done to rule out cardiac arrhythmia. We have to get a cardiac evaluation as well as, since it is a scalp one, we have to rule out any head injury also. We can go for NCCT head also, ma'am. Then once the initial resuscitation is complete, then we have to, since electric contact burn, there might be a, we have to wait and watch as of now initially.
Along with that, we also get an ophthalmic consultation as well. So there appears to be a burn around the eyes as well. And then, so we, as previously, rule out head injury, rule out any cardiac anomalies, other associated anomalies. Then we
Don't repeat the answers.
take up the patient for after initial resuscitation of the patient. We get the blood workup done, KFT and everything. And then we make sure there is no compartment syndrome in the hand as well. And we take up the patient in this specific patient. So we take up the patient for debridement later on.
So this patient's the images that you're seeing, no?
Yes,
Do you think, I mean, what stage is it, like, how acute do you think is this?
Sir, this seems to be
Few days old, sir.
At least 4 or 5 days old, sir.
How do you say that? But how do you estimate the age of this burn? Like, why do you say that it is 4 or 5 days?
Because in the first picture, the scalp is exposed, the bone is, we can see the bone, and around the eye there is development of the eschar, sir.
And also there is also surrounding the eschar, there is also raw area, so probably the eschar is slowly separating.
Yeah, so some amount of granulation tissue is already seen.
Yes, sir.
And the calvarium has got completely exposed by now.
Yes,
So
sir.
probably not at least not an acute day one injury kind of thing.
Yes, sir.
So opthal evaluation tells that the person is going to not have any vision on that side. So what is now the next plan? Now you can see that this patient is on the table.
And
So what do you think is the plan for that particular day by this team, whoever is operating?
so we can education. We can go for enucleation of the eye, sir. And
Not
we have,
I'm talking about the overall management. Everything, including the hand, the scalp, everything.
So we consider debridement of the patient, sir. Also, we take assistance from neurosurgery as well, because if the outer table is involved, I mean, since it is exposed, you might need their help as well. So initially consider go ahead with the debridement, sir.
Followed by flap covers for the scalp, sir. And
What
we have to
X-ray would you
for the donor-
advise to see whether the outer table is involved or not?
Sorry, sir.
What X-ray would you advise to see whether the outer table is involved or not?
X-ray.
What X-ray?
lateral view of skull X-ray, sir.
It's called tangential view. You just shoot that particular part. Go ahead. Yeah.
Why do you think you require the help of a neurosurgeon at this particular stage?
So if the outer table is infected or so, we might have to remove it, sir. So it's better to take the help of a neurosurgeon.
In
sir.
case of any uneventuality, sir, we should keep the neurosurgery team ready with us, sir.
In this particular patient, what do you expect?
Yeah, this you're saying it is day 4 or 5 of the injury, no? Do you really think you will have infected tissue over there?
No, sir, not on day 5, not so early.
What will be your defect at the end of your debridement?
Defect will be extending in from the right eye, sir, and over the dorsum of the nose to the posterior part. We cannot see in this pic. It can be reaching up to the occipital region, sir.
Hmm.
Okay. So what would be your plan?
We have to look for the donor site also, because we have to give flap cover, sir. So we have to assess both the thighs in case we are going for a free ALT flap or.
What do you think has been done in this patient? What other images are there?
So,
Some flap cover has been done for the export skull and
tissue expansion.
What flap cover?
Sir, it could be a tissue expansion must have been put initially. So looking at the density of hair, tissue expansion of the viable areas of the scalp must have been done and must have been advanced, sir, partly. Because
From the
density of
post-op picture, what do you think has been done for this patient? From the picture which you see
it
here.
look like free. It looks like free ALT flap.
Hmm.
Free LT flap, all the hair.
That could be a blunder, yeah. Hmm.
Oh,
tissue expansion and advancement, sir.
That's the
so if you
possibility.
look at the type of injury, he's got a globe injury, the hand injury and everything. Do you think that they have sufficient time to wait for tissue expansion to happen right now? Or do you think they've been waiting for the past 2.5 or 3 months, 2 months at least?
No, the question that I asked was what you think was done because of the post-op picture that we have here. So
Yes,
they have.
So if you are unable to identify the particular flap, then should we pass the question to the next team?
Sir, scalp rotation flap, can it be?
In progress.
Scalp rotation.
Scalp
flap.
rotation.
Yeah. So even though you cannot see the rest of the scalp at the back, no, that's probably the most likely thing that has been done.
Rotation.
Anybody else can answer in a better way? Other teams?
Ma'am, it's a scalp transposition flap.
Second team, yeah.
Ma'am, RML team. It's a scalp transposition flap involving whole of the occipital area.
Because the posterior
Because we can see the posterior hair follicles in the first picture, most likely. So it's a transposition flap being done, and most likely in the occipital region, STSG has been done.
or the donor area.
Team 3?
Ma'am, it looks like a scalp transposition flap.
Okay, at
Since
the
we are
end, I'll
unable to
give
see
the
occipital
details
region.
what it was done. So
Looking at how can
we
you say
can
it's
go ahead.
transposition
Sir?
Just looking at the flap, somebody said the first team said rotation, no? So you're saying transposition. So just looking at the end result, how are you able to say that it's transposition?
Based on the defect size, sir.
Sir, just inferior to hairline, still we have some skin which is covering over the dorsum of the nose and lower part of the orbit. There is not just hair and there is a part of normal tissue also, normal skin.
Okay.
So how it differs?
Yeah. So what is the inference of that? What has that got to do with the type of flap I'm asking actually? I'm sort of
Team 2 wants to
Sir,
answer.
sir, defect size is one reason, and we can see in the post-op picture that there is a linear scar-like thing on the flap in the middle, which was seen on the center of the defect, skull in the preoperative picture.
Okay.
No, one word. What is the flap? Name the flap. That's all. Any team.
Ma'am, transposition flap. Because
Okay.
I'm
No
saying
explanation. No explanation. Only one flap. Name that. If it is not there, we'll proceed to other things.
Occipital artery based transposition.
Transposition flap.
Okay. Transposition, rotation, everything is over. So panelists can proceed to the next question regarding the flap. We'll explain at the later because time is short. We have to cover more.
So if you're thinking of doing what is the other plan? You said you want to look for a free ALT. So where will you base it upon? What will be your recipient vessels?
This case could be
temporal.
This is for Team Safdarjung. He has to answer first.
Superficial temporal, sir.
What do you think has been done for the upper limb?
Maybe as a groin flap has been done for that left hand side.
Any other options can be thought of?
A pedicle groin flap or a
Looks like a pedicle groin flap only. Cannot see any other incision proximally for a flap.
Pedicle flap
Pedicle
only,
groin
ma'am.
flap only.
What other plans can you make to cover this kind of a defect?
Radial forum.
Paramlegal.
Posterior interosseous artery based perforator flap, sir.
Okay.
Sir, we have 2 more minutes for the
Can also
discussion.
be done.
Reverse radial can be done.
Abdomen flap can be done.
Okay. Okay.
What would you do?
It will be your flap of
The
choice.
elective one, we would go ahead with the pedicle flap, sir, groin flap.
other 2 teams also can answer?
What do you think he will require now in future for the scalp, for his forehead reconstruction?
Tissue expansion for the donor area at the occipital region and the left temporal region. So tissue
Decrease the alopecia area.
Sorry. Can you repeat that, please?
Team 1.
The tissue
Team 1 tissue expansion can be done so that we can have a hair bearing area over the part where the STST has been applied, sir.
I'm talking about the forehead reconstruction now. I'm worried about the
But
occipital.
with the laser hair removal, sir.
Sorry?
Laser hair removal, sir.
Laser hair removal. Okay.
Anything else?
Anything else?
Next team.
Prosthetic coverage for the eyes, sir. Any prosthesis for the eyes?
He's talking about the forehead, yeah? Stick to the forehead.
Sir, we can for team 2, for forehead reconstruction, we will do deepthalization of the flap thinning in the forehead region with deepthalization and removal of soft tissues, and followed by STHG.
Or we can do the electrolysis of the hair follicle, so we can remove the forehead area, specifically forehead area hair removal.
And it has the advantage of making by itself, because of the hair, there is the eyebrows are reconstructed by themselves.
Anything else, team 3?
The Crane's principle, sir.
Very good.
Go
Okay.
ahead. Talk about
What
it. Yeah.
is it? Very good.
So in Crane's principle, we raise the flap and we give it insert over the defect, and later once the flap settles, we raise the flap back and give insert over the donor area, leaving this in the meanwhile over the defect area the subcutaneous tissue develops, and then the defect can be covered by a thick grafting.
Over 3 weeks of time, it will be de-epithelialized. Epithelialization will take over, sir. After that, we will do grafting. This is Crane's principle.
I hope what you're saying is exactly what we are understanding. But anyway, so I think we are run out of time now.
Moderator time.
Yeah. Just
Moderator, please.
2 minutes is more than enough for me. Tell me one thing, team Safdarjung. If this would have come to you on day 1, what would have been your strategy? And you said 4-5 days. It looks more than 2 weeks old.
Yeah.
But still, if it had come to you in the casualty within the first few hours, what would have been your strategy? Quick.
So resuscitation initially, we have to look for the urine output. We have to rule out the
strategy. That will be done by strategy, surgical part. When do you want to intervene? What will you do?
Early debridement, sir. And then we have to relook, sir, because there are skip areas in electric contact burn. The tissue might appear healthy on table, and next day when we go again, it might have necros. So we have to be sure that once we are going for flap cover, the tissue is viable, sir.
How many days that would take you to cover it?
It takes 10 to 14 days, sir, in cases of electric contact burn, once we are sure that no further necrosis can be there, sir.
Okay. Can be earlier. We normally take 7-8 days maximum, but still, go ahead. Perfect. Number 2, forehead. You mentioned that we do a crane principle. Why do you wait after the crane principle? If you're lifting up the flap, you are leaving behind something. Why can't you put a graft straight away?
We can go ahead.
No, that was somebody else who answered the
I
question.
think it was team 3.
Team 3.
Team 3. Gandhi, is it? Gandhi Medical College.
Go ahead. Sequence slightly mixed up.
Sir?
Answer the question.
We are giving the flap over a compound defect. So we wait for the flap to settle and the subcutaneous tissue to develop so that it becomes a graftable area to graft it later on. That's the reason we need to wait for 3 weeks.
You got to revise your crane principle.
Yeah.
When you do a crane principle, you leave behind something on which you can immediately put a graft, or maybe even do a small free flap to make the forehead look very, very attractive.
Galeal.
So not galeal. The part of the flap itself you leave behind. You pick up only a particular thickness of the flap. Some part of the flap which is already settled on the carrier area, you leave it back there only, and then you can directly graft it. You don't need to wait for 3 weeks.
Okay.
Right. Thank you, Dr. Lakshmi. That's enough.
Judges, please. Judges or any senior faculty would like to ask any questions to the team?
Can I see the picture again?
Yes, sir.
You see this area in the middle of the scalp, in the midline, there is a raw area. And the flap has been raised and transposed to the defect, let us say. Now, and there's a scar representing that previous raw area. Can you explain me how this flap has survived beyond that scar? Normally, we say that if there is such scar, it's risky. But in this case, it has been done and it has survived. How?
Scalp has a very good vascularity, sir.
How? That's what I'm exactly asking. What is the scientific basis of vascularity in this particular flap, although there is a midline deep wound? Explain how this flap has survived without necrosis. Team 2?
From the subdermal plexus, sir, scalp, that galea contribute to the robust blood supply, and there is a rich subdermal plexus, sir.
So you mean to say that it is not deep enough to damage the galea? This is what to say? Any other, that is one possibility. Any other, team B? Any other reason how this flap has survived?
Vessels. So because of the posterior auricular vessels, occipital vessels, which are there. So
In the flap, the based on the transposition, the flap will survive, and the later on the margin of the face also take the healing part.
Team 3? Team 3?
Sir, instead of
See.
just a random flap, if we have based it on occipital or postauricular also, and if the wound is not below the galeal plane, it would have survived.
I feel that the galea was intact. This is not deep enough to damage the galea, number one. And number two, if you see posterior to the end point of this ulcer, there is scalp continuity, not scalp. And therefore, whatever you have incorporated as a vascular supply, that has supplied from behind also. So galea plus that one. Therefore, it has survived.
Yes.
Thank you.
Suggestion for all the three teams,
So-
look up for Sir's paper on the vascularity and the flaps.
May I ask?
Yeah, go ahead. Ambar, Aru, yeah.
Yeah, what is the scalping flap?
What, sir?
What is the scalping
He said,
flap?
what is the scalping flap?
You are seeing the picture, no?
You go
That's
to
the-
back, go back, Rohit.
Can it be called a scalping flap?
He is giving the answer to you.
Yes, sir. We go from the scalp to the forehead. Yes, sir. We bring the scalp to the forehead. We can say it is a scalping flap.
Have you seen any being done?
Haven't seen any, sir.
People don't do it anymore, but it's a very good flap.
Normally, I think it is used for nasal reconstruction, sir.
Especially in the challenging cases like
think
this.
Time is over, I
No,
think.
madam
Rohit.
is already told.
So this is
Ma'am,
done at our institute. Time is over. 2 minutes, 1 minute I'll take. So this is done. This flap is done within 10 days only. So evisceration was done, and the entire parietal, temporal, and part of opposite parietal, based on with very narrow pedicle, including the superficial temporal vessels. A big scalping flap is rotated and transposition done, and posterior aspect also closed, and it is moved. Even the raw area, what you are seeing, that also has advanced towards the face and towards the defect to cover. So that what is healed is what you are seeing, that after debridement, the tissue which is on the galea. Okay. So the a part of galeal scoring also done, and how the Bhattacharyas are told, the posterior part of the scalp is intact and the blood supply is preserved for the scalp beyond the raw area. It is not very deep, but still it compromises the blood to the distal part of the flap. But because the posterior part is intact and the blood supply is from the vessel included in the scalp, and the bone we did with burrs, we have scraped the whatever the dry bone and not removed the outer cortex and the nasal bones. And he came for the follow-up. This is after, I think, 1 year. And later on, we wanted to do secondary procedures, but he didn't turn up. But he's very happy with one eye and this result. And for the thumb defect, we did PII flap, post-interosseous artery-based flap. I think we can
And
move to
sorry,
the
madam, sorry
next.
to interrupt. Sorry to interrupt,
This
madam.
is a scalping flap only we did.
Yeah,
Tell
and
Umar.
students should know, and they should know that this is only the first procedure. Now, secondary
The
procedure is to be
secondary
done.
procedures to be
As Venkatesh sir
done.
was saying, yeah, you have to raise the flap again. Tissue is on the bones. You can graft that and you can put whatever flap you want to put, deposit back at its own place. You can deposit it back because you cannot want hair. Graft is better than hair on the forehead as well as the root of nose. So you raise
Yes.
the whole flap, you deposit it at your donor site, whatever flap is needed, and rest you can graft. What some team was saying, Crane's principle.
Yes, yes. So
Yes, yes.
we thought of doing that only, but he didn't turn up the again for secondary procedures.
Right.
So that's the best way of doing it. One sitting, we can provide the entire forehead, right? Yeah, you can go to the second spotter. Dr. Umar and Dr. Praveen,
Yes, sir.
lead the
Yes,
questions,
ma'am.
please.
Team is same, Safdarjung team.
Yes, sir.
Now you are seeing 3 pictures. Right? What is your diagnosis?
It's like a postponed contracture of the elbow, flexion contracture of the elbow, wrist,
Right hand, sir.
and
There is a
fingers. So there is a flexion contracture of the elbow, and with the flexion contracture of the wrist, with extension of the metacarpophalangeal joints, and flexion of the flexion contracture of the interphalangeal joints, with reversal of the palmar metacarpal arches, sir.
How will you approach? How will you approach this patient you are seeing in your clinic? How will you approach this patient?
So any these contractures we go from proximal to distal, sir. So we initially go ahead with the release of elbow contracture and then with the contracture of the hand, sir.
We'll first do elbow, then hand. Why? What is the reason of releasing elbow first, then
sir,
hand?
we have to
Any
ask the patient.
advantage of listen, any advantage of releasing elbow first, then going into the second stage to the hand?
So only thing is that
So normally we go from proximal to distal, but in cases the patient is right hand dominant and the hand is, as we can see in this photo, the hand is severely affected. In that case, we can give prior to hand also, sir. In this case.
What is the advice do you have to tell?
What
when
would you
compared to
do?
the elbow and hand, which is preferable
in front of
functional
you, what
position
will you
and
do?
which is required?
So will you go for hand or elbow?
Sir,
Go with
I
the
will hand first, sir. Wrist and hand first, sir.
Hand first. What will you do? Do you need anything else to have a better idea of the anatomy of the hand?
X-ray, sir, we
do
get
something?
X-ray of the hand to look for the condition of the joints, sir.
Which joint?
The wrist joint, metacarpophalangeal joint, and PIP joints, sir.
What exactly are you seeing in the picture? What has happened? If you
Sir,
are
there
asked
is-
to describe this contracture, wrist
Sir,
as well as the hand.
I will start from the hand. The hand is a system of intercalated joint where distal joint take the deformity totally opposite to the proximal joint.
No, please,
Here the
please
wrist is
listen. What is the deformity here? What are you seeing in the picture?
There is a
What has
flexion
happened?
deformity of the wrist. There is extension of the MCB and flexion of the interphalangeal joints. This is a position of comfort.
And it is an intrinsic minus end, sir.
Team second
It
or
is a
B.
position
Can
of
you
which
add something more on this?
With
Team
the
three.
with jet deformity of the thumb.
So it's the swanning deformity of the fingers.
What about the wrist?
Wrist is flexion
Okay.
deformity.
There is a reversal of metacarpal arches there, sir.
What about the joint? What about the wrist joint? Team 3.
Yes.
Wrist is an hyperflexion, sir.
You know.
Sir,
Team two.
according to Macaulay, it's grade 4, sir.
Poly grade 4. What is this hump due to?
With-
Can you see the hump there on the
With
wrist?
wrist joint dislocation or subluxation, most probably.
Subluxation of wrist joint.
What? That is the thing there. Joints are subluxated. And no team among you
Yes, sir.
all. Only team 3, they answered. This is a subluxated joint. Right? Dr. Praveen?
Next.
Dr. Praveen.
Yeah, one question I have. When you release the wrist joint, what problems do you expect upon releasing the wrist joint? I mean, the flexion contracture at the wrist. What are the problems which you anticipate?
Just the vital structure, the nerves and vessels will get exposed and tendons will get exposed. And also, since this is a very severe contracture, the vessels, if exposed, can go into spasm and the distal vascularity might get compromised.
There might be shortening of the neurovascular structure and tendon structure. So while releasing the contracture, we have to look for distal vascularity also, sir. And we have to anticipate for flap cover also, sir, after releasing, because vital structure might get exposed. So we have to provide a flap cover also, sir. There will be tendon shortening also, sir.
Are you sure you can release it fully?
Fully.
Wrist?
No, sir. It's difficult to release it fully, sir. Whatever,
Can you do
there might be
something? How can
shortening
you
of the
release
tendon.
fully? If
So
you
what
want
will
to
you do if
get it
We have
you
to do
come
it.
across that problem? What will you do if
Yep.
you come across that problem?
What
So
can
we
you
have to
do?
do it in stages, sir. You have to do it in stages, sir, because there will be shortening of the
What
tendons
stages?
also,
What
sir.
will you do?
I could not understand. What stage? In the first stage, you will release half. Next stage, one more half. You mean to say that? Or something else?
You can go for distraction also, sir.
Okay. You will
And
release
serial stretching
and
exercise.
you can, some team B can add on it. Team B.
In the release,
We
we
can
have to see
release
the distal vascularity. At certain angle, the vascularity will go on. Below that angle, we have to release, and we have to cover the a vital structure with the flap coverage, either pedicle or either free flap. For the wrist area, we can do the groin flap if the donor area is healthy, and abdominal flap also in this hand. If both the option is not available, then we have to go for the free flap, but
And fixator.
and fix the in
And
certain
splintage.
position
We have to
and
give splintage to
with the
the.
splintage.
Team
We have
3,
to
can
do
you
serious
add on
splintage.
this management?
You have to give
Sir, I
serious
would, we would
Team three.
release only the contracture over the wrist and give an external fixated support to the wrist joint
Extensor fixator
with a flap
support
cover
means
and
extensor fixator
external fixator for the bones, sir,
for what? With
to
what purpose?
stabilize.
What will they do? What will they serve?
Sir, since the wrist joint is mostly subluxated, we need to bring back it into position after release
My
and give a
question
flap
was,
cover.
if you could not, a simple question was simple, if you could not get it to the neutral, then is there any option available to you? You are covering the
Yes, sir.
with the flap. Is there any option available to you which you can do to get it to the neutral?
So we release
Functional
the contracture and
arthrodesis
can start distraction.
functional.
Now we come to the back to the team 1. Team 1. You want to add?
Sir, after release, we give serious plintate, sir.
And we can apply option of distraction will be there, sir.
And when the joint is involved, we also do capsulotomy.
Can you
We
tell
can do-
me what are the basic principles of releasing a hand contracture? What principles you will keep in mind while you release a hand contracture in general?
So we release until we get the normal tissue. Until we get the normal tissue, try to make sure the vital structures are not
Until you
exposed.
get the normal tissue. I could not understand this. What normal tissue?
The fibrotic and
Sir,
fibrotic
our aim is
tissue
to release the contracture full to achieve full motion, sir. If any underlying structure are exposed, we have to give a flap cover, sir.
And what are the basic principles of hand contracture release? What do you want to achieve? If you release any hand contracture, there are something in some principles which we follow, which we have to achieve any function of the hand. What are those principles? Can you enumerate one or two? What is your goal in a case like this? What is your goal in the
Sir, to
wrist? What
give-
do you want?
Sir,
What do you
to
want
give-
in the wrist? Either neutral
We
or a
want
little
wrist in
extension, right? Now,
little
what is the
extended,
goal
sir.
in the hand?
Our
What is the goal in the hand?
goal is to, sir, reduce this subluxation of the wrist joint. Either it should be in a neutral
Wrist
position
is
or slightly
gone. Wrist
extended.
you have replied. Now I want the hand proper. Maybe the
Yes,
MP
sir.
joints, maybe the thumb, maybe the digits, all fingers. What's your goal?
Goal is
correction, the reversal of the arches, sir.
and correction of this hyperextension of MCP joint, sir. And this flexion of the PIP joint we have to correct, sir. So we have to bring the metacarpophalangeal joint in flexion with IP joint in extension, sir.
To give the
Johnson?
intrinsic. To give the intrinsic plus position, and in this
In functional hand.
Yes,
raised
team
joint,
B.
releasing of the elbow joint contracture will also add 10 to 20 degree of the relaxation of the wrist subluxation
We are
also.
considering hand. I think for elbow in this patient may be an advantage. We'll go to later on to that. We are on hand only. Any more principle you want to add which the team one is missed?
To make
on hand contracture?
to make the hand in the intrinsic plus position, so they can able to do some function of the
That is
hand.
already done. That is already done.
Sir, we have to
You want
keep
to
the
add?
thumb
I
in
want to
abduction.
add.
We need a thumb in abduction, sir. We have to look for the first space. When we look if there is any contracture of the first dorsal interossei or adductor, we have to release that, sir.
That means you have to release what?
First web space.
First web
for
space.
contracture release.
So
First web space.
these are among the principles of the hand contracture release. Dr. Praveen, you want to add something? You want to ask something?
Yes. How would you retain the posture, the position after releasing?
So the wrist is extended to
No,
20.
that's okay. How will you retain it? You are using any splint or K-wires or what? Any plan for the fingers?
Fingers we have to do, sir,
K-wire is
K-wiring,
required.
sir. We have to do orthodontic. We have to do K-wiring, sir.
In which position?
Sir, we have to, we need wrist in slight extension, MCP joint in full flexion and IP joint in extension, sir. This is a position of immobilization.
MP joints in full flexion means what? What would be the angulation of the MP joints?
Seven-
Not, you mean full flexion?
No, sir.
No, it's a 70 to 90 degrees, sir. And
That
IP
is not
joint in
full
extension.
flexion. That is the ideal is 70 to 90 or 80 maybe.
Sir, time over, sir. Can we move to the
Yeah, sure.
moderator?
Moderator questions.
Anand sir.
Yeah, the way is simple. He asked you the basic principles. The basic principles are very simple. You try and remove as much scar tissue as possible. Try not to expose too many structures. In case if they are exposed, think of how to cover them up and then get all the joints into functional position. Somebody mentioned capsulotomy. Very difficult to do in the wrist joints. You might be able to do in the MP joints, fine. Wrist joints, very difficult. You just won't be able to see a capsule properly, all fused together. That's all. And then the other thing is about the fixators. It's a good principle, but then probably you have to keep the patient in the hospital and follow it up. It is only feasible in a government institute where they don't have to pay for the bed. In the private, it's a very difficult proposition. That you put a fixator, call them after every 3 or 4 days, try and extend a little bit. so that after about 2-3 weeks, they have a neutral hand. All said and done, good. Flaps. What flap is advisable in this case? He would need a flap, definitely.
Sir,
Team
in
A,
this
is it?
case, we can go ahead with groin flap, sir.
Once you, what is the harm in opening up the wrist as well as the elbow together?
Could you please repeat, sir?
What is the harm in, or what is the disadvantage of releasing the elbow and the wrist and the MP joints together in this case?
It will be very difficult to, in case we are planning for a groin flap for the hand and we are
Position.
releasing elbow also, it will be very difficult to maintain that position, sir. Because
Why do you say that?
Because, sir, if you release the elbow, we have to keep the elbow in extension, sir. And then to bring the hand for the groin flap, in that case, it will be difficult to.
No, I didn't say groin. You said groin flap. There are other flaps also.
Even then, also, sir, it will be, position will be difficult, sir. And
vascularity.
You got to make difficult things easy in life. Try and do it in one single stage if it is feasible. There are multiple flaps. Think of the options.
can be, sir, hypogastric and groin flap we can do if we are planning.
The wrist we can do a groin and another flap for the elbow, sir.
Also,
If
I
the hand
think
is kept straight.
in this case, elbow contraction may be an advantage because your position may be helped by the contraction by the flexion of the elbow. If you want any pedicle flap from the groin or elbow, right? That may be an added advantage. And along the principles of the release of the contractures, yes, we normally go from proximal to distal, but seeing the deformity and the severity of the hand contracture, it is a must that we should we should do first the hand, give some function to the patient, because elbow flexion can be done later on, but he will also have some function. So one of the principles is very important in dealing with these hand contractures is that you try to give them maximum in the first instance so that the patient can say that I have achieved something. So the compliance is also good.
We are
So if you
motivated and
only release the elbow, there will be no function of the hand. So maybe patient comes, the patient will never be happy. If you give him flexed hand, thumb in the abduction, whatever you want, contracture release of the hand, he'll be happy enough that he has achieved something, some function is restored, and he may come again for the rest of the whatever we have to do. So try to give the patient maximum relief, maximum function in the first stage, then you can go on the later.
So judges' time.
Yes.
So Bhattacharya sir would like to tell.
I just want to know how will you prognosticate about the functional recovery to the patient and attendant? They will ask, sir, everything will be okay?
So first of all, we have to tell the patient that patient will require multiple stages of surgery, sir. And because seeing it is a very severe contracture, Macaulay is grade 4, which there is loss of underlying architecture also, sir. We have to prognosticate accordingly.
And also we have to motivate them for the physiotherapy as well.
Okay. Second is, if you see the circumference of the forearm, it seems to be much reduced. I have not seen the other forearm. But can you tell me why it is reduced?
Sir, disuse atrophy.
Why the circumference is reduced?
Disuse atrophy.
Disuse atrophy of what?
The muscles of the
muscles of the forearm, sir.
Correct. And the third thing is, suppose for elbow you have three options: bipedical release, incision and release, and excision of scar and release. Which one will you prefer?
So we can go for bipedical release because the skin brace act as a flap, sir. And there
Is
are
this case is suitable for bipedical release?
In this case, because hypertrophic scarring is also there, sir.
Team 2?
There is no normal
excisional release. Ideally, is the excisional release to give some aesthetic appearance, improve the aesthetic contour of the patient also. Because in total, the hypertrophic scar is limited. And if we have adequate donor sites, then the ideal would be excisional release and grafting.
Plus, they added the soft tissue to the wrist side. If we do the bipedical release, the deficient in the wrist joint area of the tissue.
No, I'm asking about elbow.
So
Is this
excisional
case
release and STHG.
Is this case is suitable for bipedical release?
No,
No,
sir.
sir,
There
no,
is
sir.
No, sir.
proximally
Why
and
not?
distally the skin is not.
We should do an excisional release, sir.
Why it is not suitable for bipedical?
There's no normal skin in between, sir.
Correct. Thank you. Normal
Sir,
skin across the joint.
Yes, sir.
okay, sir, we'll move to team 2, sir, now. Team 2, Gamara, their first spotter.
As Dr. Praveen and Dr. Umar should lead the questions.
Yes, what
Thank
would
you,
be the
team one.
diagnosis for this?
So it looks like a electric burn because of the involvement of the deeper muscles and soft tissues involving the right shoulder and bilateral upper inner thighs and the groin and upper side of back, right side of back.
Do you think this is a high voltage injury or a low voltage?
Yes, sir.
Yes, sir.
High voltage.
High voltage injury. High
Okay.
voltage electric injury.
Okay, why do you think there's a different zones of this injury? What is the cause for the different zones there? You can see the burn injury is
burns.
not uniform. What is the reason for it?
So because of the contact primary site of the entry wound. So higher chances of injury at the point of entry and at the point of exit as well. So that might be the reason for diffuse variability of the
Injury.
depth of burn injury. And more so, sir, because of the arcing as well, internal arcing that occurs because of the electric burn injury.
Okay, which tissues do you think will offer maximum resistance and which least resistance?
Sir, now is a least resistance and bone is the maximum resistance.
Okay. Another question, while during resuscitation, any important things which you look for or you want to rule out, or you check for? Any 1, 2, 3?
Sir,
Any?
for initial 48 hours, the cardiac issue is the main issue, cardiac arrhythmia. So we have to do the ECG monitoring. And
Okay.
And for renal function, we have to look for rhabdomyolysis and myoglobinuria. So we look for the urine output and its color. Because
What
the
color
patient
do you
has
expect if there is muscle necrosis?
cola
colored urine.
Okay, and what will you do if there is myoglobinuria?
we have to give the
Alkaline.
as per the alkaline, give more fluids and alkalinization of the urine. So we can avoid as much as possible of the acute kidney injury, AKI.
So give diuretics to increase the renal flow, and we use soda bicarb to alkalinize the urine.
Okay, anything else you look for?
And sir, we use because it's electric burn, we look for though it's a late complication, but we look for a cataract also, get an ophthalmological opinion because they have chances of cataract formation.
Let's
And,
talk about the
Electric
acute
burn
stage
also
here.
causes
Not talk about
also leads to convulsions. So a neurological opinion and NCCT head.
Now, do you look for any fall from the height? Any vertebral fractures?
Yes, sir.
Yes, sir.
So if the history is suggestive of electric burn at a height, then it's naturally when we need to rule out other injuries as well in the primary survey as well as in the secondary survey, followed by relating to the traumatic history of trauma and other injuries. We go on to we go into we look for other
Possible
injuries as well of vertebra, or it could be of skull, or of intra-abdominal injuries as well, or pneumothorax. If it has fall from height, then it might suspect pneumothorax as well.
And due to high voltage injury over the shoulder, then we have to do the chest X-ray and look for the any pneumothorax, because there is a possibility of
And because of the depth of involvement, we have to go for X-ray of the shoulder joint to look for any dislocation that can occur because of the electric burn
and
injury.
that side of the upper limb vascularity also we have to look for.
What about the movements of the shoulder?
The movement.
Sir, in the photos of the first photos, there both the hands look within normal
limits.
But on the examination, we can do more differentiative and detailed evaluation.
So do you think the shoulder joint will be exposed?
So likely, because after debridement only we can comment upon the exposure of the shoulder joint.
Because the anterior margin may be that below to the deltoid muscles. If the
Okay,
deltoid
what is your plan of treatment management?
Sir,
Resuscitation.
staged resuscitation
Hmm.
and monitor the vitals, and then staged debridement of the entry wound of the shoulder side and both the perineal wounds. And then in 7 to 10 days, when the necrosis
Has settled and it has not progressed, when we go for flap cover.
Flap cover, depending on the donor area and the burns area size and their dimension.
What flap cover?
Lateral arm.
You want to flap the entire area? Or
So
anything
no, only
specific?
the defect area involving the shoulder after debridement. So rest, as we can see, in the rest of the areas, there are healing. They are in the posterior shoulder, posterior back. It's in the third image. It's second degree deep, but it can be grafted after debridement. But mainly the shoulder area where there is actually a defect post debridement, then we need to give flap cover only at that site. Rest can be grafted.
And we can look for the any bone is exposed, then the flap cover needs to be given. Rest we can wait and grafting after the granulation will.
You don't want to do any imaging of the shoulder before it?
Sir, X-ray of the shoulder joint.
X-ray of the
To
shoulder
look for fracture associated.
You know the damage, extent of damage?
And we can also look for the brachial plexus aspect also, because high voltage injury over the shoulder joint, and then there is a damage to the nerve tissue also of the right side of the upper limb, so we can look also that the neuronal tissue injury also.
Clinical is not sufficient to make out brachial plexus injury in this case?
Yes.
So clinically, we need to assess the patient clinically before coming on to a diagnosis of brachial plexus injury. Clinically, not in the photos, but we need to actually examine the patient for brachial plexus.
Okay, what about the groin area, perineal area?
So groin looks mostly deep, second degree burns, where we need to do debridement with grafting.
And position, how do you immobilize it or splint it?
They're in abducted position, 15 degrees. 15 to 20 degrees abducted position of the hips. Hip joints.
With slightly externally rotated of the both the lower limbs.
Now,
okay, Dr. Swaroop, anything?
Yes. You tell me, seeing the pictures, what is the mechanism? What is the mechanism of this injury? What are
Sir,
you
the
seeing?
upper shoulder aspect is the entry wound, and both the perineal, both the side of the lower limb perineal wound is the exit.
Might be exit. But
Might be exit wound.
Because we can't see the foot, so we don't know the exit wound.
What are the mechanisms? What are the other mechanisms? Injury can occur in electric burns. one you said entry and exit, huh? To do the
Yes,
flow
sir.
of the current, right? One is this. What are the other mechanisms?
The electric flash burns.
over the
Right.
shoulder and back side.
Electric flash burns.
Then we have if because of the flash there is the clothes catch fire, then it can lead to other thermal burns as well. That's
Right.
another. And then it could be flash, electric
Use
current.
inhalational thermal inducing.
No, thermal. Electric arc, lightning, and flash burns.
What is arc?
Sir,
arc?
So electric arc, when there is not when there is when there is in between the source and the receiver, between the source and the patient, there is high, because of the conductance of the air, it causes generation of electronic magnetic field that causes
Team one.
Sir, the free air around the electric contact burn, the particles get ionized. So that air act as a conductor of
It will
electricity.
turn to team.
So team 2 questions will be passed on to team 3 if they don't answer.
Okay, team 3. What is the mechanism of arcing?
So in arc injury, the environment surrounding the body acts as a medium for the current to pass and cause the burns.
Team 1, can you improve a little bit on this?
Sir, basically the electric current flows from an area of high resistance to low resistance. The air present between the electric source and the body gets ionized, and there is a formation of burn, sir.
It acts
Flash
as a
burns.
conducting medium.
So ionization of the particles from the high potential to the low potential to the high potential actually.
So there's a potential difference developed between the source and the body.
Yeah. Not source in the body. Between the two parts, actually, how does arcing occur? What is the mechanism? You are not telling that, no?
Sir, the arcing occur because
Why does the arcing actually take place? Let team 2. You are in the focus this time, no? Team 2. Why does the arcing take place?
Sir, arcing happens when there is, for example, from the shoulder to the wrist, there occurs arcing of the electric current. This happens because of the resistance between of
Can it
the
arc from the shoulder to the wrist? Have you ever seen?
arcing, so external, internal arcing.
I have no idea about these external, internal.
Arcing is different.
तो बोलना.
Actually, across the joints. Actually, it is what you
Sir,
see there are the jumping.
Several aspects of the wrist,
because of sweating, sir.
Yeah.
So
Because
last
of
Very
sweating,
high
over
temperature
the
is
flexor
developed,
aspects of the
maybe in thousands. Right? Second thing I want to clarify, you said that cataract can occur. Can you tell me why cataract will occur in this patient or develop this patient? What are the features you suspect that cataract can occur? What are the predisposing factors?
So mainly, it's seen in high voltage electric burns involving near the head and neck region. In a predisposed patient who has premorbid eye conditions or involving old age patients, and when there is high chances of cardiac dysfunction in a patient with electric burns, and they have higher chances of cataract formation as well. And
you are mixing the things. You are mixing team 2, not 3.
Oh, proteinaceous. It's a proteinaceous accumulation, sir, that's causing cataract formation. Seen in high voltage burns.
So because of the dehydration of the lens, it causes accumulation of the lens protein that causes predisposes to early cataract formation.
I don't want the pathogenesis. I want which burns, type of electric burns. You
So
can
high voltage
suspect
electric
that
burns.
high voltage electric burn. Team 1. These are all high voltage.
There is
Actually, you
coagulation of blood.
rightly said that time is up. You rightly said that head and neck burns, especially which are close to the eye. And I could not find that when there is some cardiac event, cataract can occur. Is there some relation you are telling between the arrhythmias and these cataract? I don't think so.
So in association, like
Now the moderator, sir.
Coagulation of lunch proteins.
Now to moderator, sir. You are muted, sir. You are muted, sir.
Anand, sir.
Yeah.
Yes, sir.
If the current passes from the scalp down, the contact is at the scalp and it goes down, the chances of having cataract is much more. And we see within 10 years, not within 2-3 years, within 10 years, they come early. The 40s, 50s, they come with a cataract. Then yes, we see they have had a contact burn, they must go for surgery for the cataract. Not so common as you were mentioning about, no.
Any questions, sir?
No, see, the idea is, suppose if this would have come to you on day one again, what would you have done?
so we would have resuscitated the patient and taken the after stabilization and
Stage and
improved
debridement
stage
of
of
the
debridement of the
wounds, and we can
followed by
look for
coverage.
the any vital structure to be exposed, then do the immediate flap cover.
What do you mean by immediate flap cover?
Not
Suppose he
immediate.
has come to you on
Stage
day
of debridement
one.
and flap cover.
When does he go for first surgery? When does he go for next surgery?
After 7 to 10 days of the burns, when the necrosis will settle, then the first surgery, and then we can look for the
Every 24 to 48 hours, we look for the progression of the necrosis. And related to that, we do stage of debridement. And once the progression of the wound has stabilized, we take the patient for flap coverage.
How often have you seen AKI, acute kidney injury, along with electrical contact burns in your training program?
Sir, whenever the high voltage electric burns of the hand and the whole upper limb is involved, then there is a high chance of the AKI development. And
Ask you a
that type
simple
of
question. How often have you seen in your training program?
So not that often.
Okay, fine. Moment the big muscles are involved, there are chances of acute kidney injury. Idea is to remove the dead muscles as soon as possible, preferably within the first 24 hours if you have the facility, to reduce the load on the kidneys. Please remember that. That's about all.
Next, the judges time. Judges and senior people. Bhattacharya, sir.
You said about debridement, and then you said about stage debridement. What do you mean by this?
in the extensive debridement, we remove all the necrotic tissue. In the electric burns, there is a no
No. In
definitive
this particular case, first you mentioned debridement, then you mentioned stage debridement. Can you
So it's actually
clarify?
stage debridement. Yes, sir. It's stage debridement, sir. We do in stages. Like once the
that means
serial debridement.
you will allow the dead tissue to develop to get infected, and then you do again after 7 days another debridement. How many stages?
So, sir, we have to remove all the dead tissue, and we have to
Observe
the
observe the defect area for any progressing muscle necrosis and skin necrosis. Then if it develops again the skin necrosis or muscle necrosis, then we again take the patient for debridement. So in that sense,
is there any if in high tension electrical injury like this?
So the patient will develop necrosis. It's progressive damage in electric.
Your questions, your answer should be it will require a stage debridement, because in first debridement, whatever we remove, because of the progression of the further necrosis, it will certainly require few stages of debridement. Therefore, it is stage debridement.
Yes,
okay.
Yes.
Because in one go, first day you remove, again you find that something has again gone wrong. What about the scapula, right scapula? Do you think it will get exposed or not?
So can we have the image again, please?
Spine of hip will be exposed.
See
No,
the
sir.
third one.
So scapula doesn't seem to get involved. It's only after
Third
the
one.
debridement.
Third photograph.
So it's a deep burn involving the back over the scapular region. We can actually see.
Some part of the scapula is likely to get exposed because, as you said, progressively you will debride.
Yes, sir.
When you are
Spine.
seeing the groin wound or any even the shoulder wound, what makes you very careful that that thing should not happen, and if it happens, you will take care immediately. See the
So,
groin wound, deep groin wound, and deep shoulder area.
Sir, if we shouldn't, if we do debridement, then the risk of injury to the vessels, like the femoral vessels and the groin.
You are
And
coming nearer to the vessel, but my question is, what is the most alarming situation you may expect? And you will take precaution, you will instruct your staff. What will be that?
Sir, in shoulder debridement, high risk of
what is it called?
Name that condition.
It's can
Sir,
blowout, sir.
blowout
Vessels.
blowout of the
Vessels
vessels.
Blowout resulting in secondary hemorrhage.
Secondary hemorrhage.
Secondary hemorrhage.
Thank you.
This is also done in our institute. We believe in the EDAF method of protocol, early debridement and early amputation, disarticulation, fasciotomy. So, as Anand sir told, we did the debridement of the obviously necrosed tissue on day 2 itself, and observed serial debridement was done, and there was a necrosis of the spine of the scapula, a part of acromion, and the gereta tuberosity, and part of the head of the humerus also. So the orthopedician was called, and all the muscles around the superior aspect, the rotatory cuff is also lost. There was no stability for the shoulder joint at all, except the lower part and medial part. Okay. So we debrided serially the bone, necrosed bone also, and they fixed with some plates. But subsequently, there was no support for the bone also, like plates fixed. So again, K-wire was applied through the head, whatever the remaining head of the humerus, into the glenoid fossa. And as there was a big wound, I think you can see the extension of the burn wound posteriorly. It was looking very small, and you told the second degree, but it all became deep and everything was debrided. So through the infected and the necrosed tissue, we don't want to approach the muscle and take the muscle. So we did PMMC flap to cover the exposed bone and the area which is very deep, and cover the shoulder region, and remaining all after debridements grafted. So this is the final result, and now he subsequently he came for the repeated graftings, and this is the wound healed, and now the hand is little stable, not very functional.
Moving to spotter 2, ma'am. Would like to request Venkateshwaran sir and Malti ma'am to lead the questions.
Yeah, please describe what you see.
So it's a post-traumatic, most likely post-traumatic contracture of the dorsum of left foot. Post-burn contracture of left foot involving dorsum.
Why did you initially say traumatic? Just like that. Okay. Okay. So Describe it. You just said that it's a contraval. Like, how will you really describe the entire? What is it that you see has happened, and give a detailed description of whatever you're seeing.
Sir, it's a post one contracture of left foot involving the dorsum, and it's leading to secondary contracture of the fifth, fourth, third, and mildly second metatarsophalangeal joints,
with
leading to
extension.
extension at
Dorsal extension.
dorsoflexion of the four toes
Leading
at
to
the
what?
metatarsophalangeal joint.
Leading to?
Eversion of the foot. Eversion of the foot.
Causing, sir, dorsiflexion of the toes.
And
Okay.
dorsiflexion of the ankle joint and eversion of the ankle.
Eversion of the ankle joint.
Foot. Eversion of the foot.
Dorsiflexion of the ankle joint. Can you comment with this single photo?
Sorry. Sir, eversion we can see. It's causing eversion of the foot.
Which also is, I think, I mean, okay, if you want to really go about it, but I think that is more because the toes have got
secondary contraction.
is sort of like a. Okay, how will you proceed in this case?
So we'll get get the X-ray of the foot done, and
we look for the joint status also, and their active and passive mobility of the
all the
ankles
toes and
and foots, and we look for the defect area, possible defect area of the foot.
Why do you want to look for active and passive mobility of the toes?
Sir, because it might also lead to a contracture. If it's a skin contracture or involving the tendons also, we need to see for that.
How will you sort of, by clinically, can you make out whether the tendons are involved or not?
So if there is bowstringing of the if there's bowstringing of the tendons involving the skin also, so most probably it involves a contracture of the tendons as well.
In the fully dorsiflexion of the foot, the toes flexion is possible, then the tendon will be free. If the fully dorsiflexion of the foot and toes is also in fully extension position, then the tendon is also involved. Like the as per the wrist.
What is it? What you are describing? What is it called?
Tenodesis.
So, is it actually possible to elicit tenodesis in this particular case?
Very low chance.
Sir, because toes are not that actively toes are not
eversion of foot.
tenodesis sir cannot be elicited much in lower limb because the toes are not that much developed as compared to flexor tendons in the hand.
Any other team wants to answer that?
Because there is a
Team
scar
D,
over
please.
the ankle.
Team B, sorry.
Because
Team B, let's go in orderly sequence. Oh, you are already Team B.
Team C.
Team C.
Since there is a scar over near the ankle also, it is difficult to elicit the tenodesis effect here. So it is not clinically possible to clearly elicit whether the tendons are involved or not by the tenodesis effect in this case.
Okay. Madam, anything? Malti ma'am?
What is the possible duration of this? Looking at this clinically?
Ma'am, it's a long-standing. It's actually a mature mature scar with a defined contracture. So it would be a long-standing around 1 year.
More than 1 year.
So
what will be your plan in this case?
So plan would be to after blood investigations and taking for OT, and after seeing the X-ray, we'll take the patient for incisional release of the contracture. And after assessing and according to the intra findings, if the tendons are involved or not, we'll
Vessels and all
if the
we'll
vessels
see.
also involved, then we'll look for we'll do STHD or a flap cover. If the tendons are also need to be reconstructed, then we need to do flap coverage. And if the tendons are normal, then we need to go for and the paratenon is also intact, then we can do grafting.
Going by your estimate that this is a long-standing contracture, what do you think would have happened to the tendons?
Tendon shortening.
Tendon shortening might have been occurred, sir.
So what would you do in your plan?
So
First,
tendon
we
reconstruction.
have to in first stage we have to remove the scar tissue, and we have to give the good
Flap coverage.
flap coverage. In second stage, we have to do the
Tendon reconstruction.
gradual tendon lengthening.
Tendon reconstruction.
Tendon recon-
Tendon.
Why first stage, second stage?
Because in the we cannot do both the surgery in same sitting to release the foot dorsiflexion deformity and tendon lengthening.
So first we want the toes to come back to their normal position. So
And foot
if
in
we
neutral
do
position.
if we repair the tendons, then we have to keep them in the dorsiflex position, the toes. So then the idea of releasing the skin, the contracture will be gone.
Can
So
you
that's
repeat?
why,
I'm sorry, can you repeat that?
sir, we cannot do in a single sitting, because if we release the skin contracture and release the tendons and also reconstruct them, then we need to give we need to place the toes in dorsiflexion in order to for the healing of the tendons, and that will jeopardize our contracture release. So that's why we need to release the contracture first, bring the toes back to their neutral position, and then once the skin has healed, then only we go for tendon lengthening and tendon reconstruction.
No,
Team
if the
C?
tendons are short, then how will you bring the toes into normal position in the first stage?
Ma'am, we need to do tenolysis and tendon. Basically, we need to do tendon reconstruction in a staged manner.
In the
We need to
dorsum of
tendon repair.
foot's tendon, we can cut and lengthen, because the second toes tendon is very important in Indian scenario. Raised toes neutral position is a very
Is not that important.
Why is the second toe important in Indian scenario?
because the most of the Indian wearing the chappals in the second toe, and first toe is very good for the holding the chappal to
Okay.
hold the
Okay. Let's be clear about what your plan is. Okay. In your first stage, you're saying that you want to just release the soft tissue, but you don't want to, or you want to lengthen the tendon. How will you lengthen the tendons? Because tendons are short. I'm giving you the clue that the tendons are short. So what do you want to do with the tendons?
in the extensor tendon of the second toes, we have to proximally cut the second toes, and rest of the toes we have to एक दूसरे से attach करके we can
we have to
give
attach them to the rest of the toes.
combine the lengthening.
Can we pass this to team C? Any other answer you want to give?
And we can also do the proximal.
So after releasing the scar by incisional release, we have to cover with the flap cover, because we need stable skin for doing further procedures like tendon reconstruction.
Madam, the tendon is contracted. I've already told you that it's contracted. So it is part of your scar. So what are you going to do when you're releasing?
So we would release tag both the proximal and distal ends for now. We will give a flap cover. And in the second procedure, we would use
The proximal and distal ends. What are you doing? Are you You're tagging it or what? Like you're dividing it or what are you doing with the tendons?
So we can do tendon lengthening with the help of Z-plasty also.
Z-plasty,
The
facial
procedure
lata,
is the same,
facial
same
lata.
Or
Same
tensor facial
sitting, we
lata.
can do both the procedures, sir. Jet lengthening of the tendon and
with
followed by
flap
flap
coverage.
cover, sir.
Okay.
But it-
So, even though you're not really right here, we just have to simply divide the tendons, okay, wherever the scar is, okay, and you're going to get X amount of defect depending upon when how much ever the toes are going to come into the neutral position. Fine. So, if that happens, now what are you going to do?
So then we'll reconstruct that after the flap coverage. If it's when it settles down, then we have to reconstruct the tendons either using with the help of a tensor facial lata graft.
So, why can't you do it today?
Sir, we need to so because for reconstruction in the same sitting, if we do, then we have to provide splintage and coverage of we have to put the toes into dorsiflexion. Then again there's the risk of contracture.
Post-op physiotherapy.
Physiotherapy
Is also important.
Where is this dorsiflexion coming from? I'm really not
What is-
getting
Any other answer by the team? Chief?
Team C, Team A. Team A.
Sir, we
Team
can
one?
do the both the surgeries in the same setting, sir.
What will you do? Both the surgeries means what?
The tendon reconstruction and the flap coverage, sir.
Okay.
Which
So
is
with
the
what?
flap- What is the flap you are planning?
So what?
Tendon reconstruction, and we can give a free flap coverage because in this patient,
The time, we
ankle
are
seems to
crossing the
be.
time. Please close the discussion.
There is no scar over the ankle, so we can give a free flap coverage.
Okay, back to the team B. In case you want to do a flap, what flap would you plan for this patient?
So
AL.
pre-ALT flap is the first choice.
Okay.
Time
And
is
you-
over
Time is over.
for panelists. The
Okay.
moderator,
Yeah, this is now my time to ask you something. Tendon lengthening is never done on a scarred tendon. Let me first tell you that. The kind of puckering that we have seen over the tendon, avoid, as Venkat said, just divide, leave it at the position they are, and then plan your tendon grafting, preferably in the same stage. Whatever time you're putting a flap, you can put a flap, do a tendon grafting, use a fascia lata, take anything else. You can even take a plantaris from the other side and do a tendon. Or take one of the tendons from there, make it into a joint FA so that they have a combined movement. You don't require individual movement in the toes. So that also is a possibility. I would preferably do the same thing. Maybe the fourth tendon I would remove and just give as a tendon graft in the same sitting with a free flap. Or if you already delayed a flap, you can even do, if you really base cutaneous flap. Not very confident of doing a free flap. Number two, how much time do you think you will tell the patient before he can start walking? These are questions have to be answered in the first sitting itself.
If we do the tendon lengthening procedure, then after 8 weeks,
6 to 8 weeks,
6 to 8 weeks with the AFO splint.
The other teams?
Say 8 to 12 weeks before the patient can normally walk.
I would differ. I don't know about the other panelists. Why not 3 weeks? If you've done a good tendon repair and a good flap?
Yeah, absolutely. At the most 1 month you can wait. At the most.
3
Why
weeks we
wait any
start
longer?
passive movements, and then after a month we make them walk, and after 6 weeks you can make them run also. This is what I feel. I don't know about the other people. Any difference that you have with the opinion?
What is the usual healing time of under the flap?
3 to 4 weeks, man.
Then that's how we will decide.
Flap robust, good tendon repair, 3 weeks.
3 weeks.
Is the final judges or any comments from other senior faculty?
Can I see the picture?
Yes, sir.
See, this luckily the distal end, even if there is a rupture or damage in the several tendons, extensor tendons, it is on the dorsum of the foot just beyond the ankle. So that is a lucky part, because if this would have extended right up to the base of the phalanges, then you would not have had adequate tendon end distally. In this case, you will get tendon end distally adequately. That is a positive thing, as well as proximal end. So you have to excise the scar and do the tendon repair and a flap cover. Now, I also could not get why you want the tendon to be dorsiflexed when you are doing a tendon reconstruction or Z-plasty. Do you think Z-plasty? I don't think there will be any scope of Z-plasty in this particular case, because it's all damage contracted. But why you have to do dorsiflexion after tendon reconstruction? Or how do you answer that?
Too many important results.
So it is a wrong answer. You need not do dorsiflexion. Why should you at all? And as far as I'll enter into little controversy as far as movement of the allowing the movement, because this is foot. So there will be little uncontrolled movement by the patients sometimes, depending upon their how do they progress, how do they feel about surgery. So there is no harm in little, gradual movement. Instead of make them run in 6 weeks, we can make them run in 3 months. There is not a problem. But I think we should avoid a post-operative rupture of a repair tendon. So if we do caution them a little bit, then perhaps it will ultimately we'll get the result if we have done a good surgery. So that is how I will go. But that's an individual choice. Thank
No,
you.
but I agree with you, but I'm also conservative about making them walk early. It might damage things. So the basic healing period is 3 months. So let us stick to that ABC.
No. Actually, it also depends upon the literacy rate and intelligence of the patients, how they are going to
Yeah,
use.
so
We
I
have to
think we
caution
should
them
wait. Yeah.
and otherwise it's okay. Good tendon repair with a flap cover, you can make early mobilization.
Okay, sir. Moving to team 3, sir. Team 3 your first spotter. I would like to request Malti ma'am and Venkatesh to read the questions.
Right. So
Describe
what
what
is the diagnosis?
The patient here shows gangrene of the left upper limb with circumferential full thickness burns involving the right wrist and extending onto the forearm, and full thickness burns over the right lateral chest, exposing the ribs, probably electrical burns.
How old do you think this injury is?
Since there is a clear demarcation of the Jackson zones and the gangrene has set in, it would be at least past 48 hours.
Yeah.
Tell me the plan. How will you deal with this? AB.
We should follow the EDAF principle, that's early debridement and early amputations. So here, since there is already it comes to the grade 3B, I can see an arc burn also in the left wrist elbow. So we need to go for left below elbow amputation and right fasciotomy with early debridement, recheck debridements after every 48 hours, and debridement of the thorough debridement of the chest wound. And the patient is intubated as seen in the picture. So we need to look around the overall general condition of the patient.
What do you think of the chest wound?
Ma'am, we can see that the ribs are also involved.
It is looking like ribs are involved, ma'am.
looking at?
Yes.
Okay,
Ribs are involved, ma'am.
There could be
preoperative.
underlying lung injury as well, since the ribs are involved, and there could be some pleural damage as well.
So
It's
preoperative.
better we get a pulmo opinion.
Sir,
So preoperatively, what all things you want to do?
Sir,
first we have to take chest X-ray of the patient, and we have to rule out the how many ribs are involved, and we have to look for the contusion of the lung injury, and based on that we have to go with the treatment of the lung, sir.
So will you stop at just a chest X-ray?
no, sir,
No, sir.
we might need a CT scan of the chest as well. We need to look at the pleural injury and the underlying condition as well. If we need any intercostal drainage or any other injuries of the lung to get the pulmo opinion.
Okay. What else do you want to look?
So,
Left upper limb is something that you have decided to ampute. So any other investigations that you would like to do before that?
Before you proceed, what is a pulmo opinion? How will it help?
sir, if there is any pleural involvement, we would like to take a pulmonology opinion as well, since it's a medical legal case also. For the documentation purpose, definitely we would like to involve other specialties as well.
Okay. So I was just asking about the other upper limb,
Yes, sir.
possibly about both the upper limbs. Anything else you would like to do before the patient comes on the theater table?
For the right upper limb, we can go with fasciotomy of the right upper limb, sir.
No,
So
I'm
that
asking
at least we can try to save the limb.
in terms of preoperative investigations. Just like you said, CT scan for the chest, no? Anything else that you would like to do for the upper limbs point of view?
X-rays of both the limbs, upper limbs.
Both upper limbs.
Why X-ray? You're suspecting some fall from a height, is it?
So the patient is intubated as well, and from the pictures I do not, and there is a chest injury as well. There could have been probably a spinal injury also, or fall from height, which
The
cannot be
patient
ruled out just from these pictures.
is on the operation theater.
Don't consider that it is intubated for the sake of something. It is taken, photos are taken during procedure. Okay?
Okay.
Okay.
Okay, ma'am.
The patient is on the operation table, so that is why he is intubated. Okay, so
Okay. Okay.
Sir, can we answer?
okay, team A.
Team 3.
We can maybe go ahead with color Doppler for the limb or a CT angio of the limb, sir.
Okay, what are you looking for?
So we can look at the vascularity of the limb and at what level, until what level the vascularity is there, sir. And also there are deep burns in the axilla as well. So we need to any thrombosis of the as well, sir.
Can you be a little louder? Sorry, I couldn't
And in
hear you.
case in Sir, we have to look for the condition of the vessels. There might be thrombosis of the vessels, sir. And in axilla also we can see a deep wound, sir. In later cases, if you want to a free flap or something, so we can look for the recipient vessels also, sir.
Okay.
And
And
mainly at this stage, decide the level of amputation, sir.
Right. Going back to team C. Ma'am, anything? Malti, ma'am?
Yeah, I want to know about the chest. How are they going to? They said they will amputate the left limb, upper limb below elbow, and debride the left, right wrist and forearm area. What about the chest
With the
wound?
fasciotomy. Ma'am, chest wound also we would
have to give thorough debridements of the wound, ma'am. After healing of the complete wound, we have to go for flap coverage of the wound, ma'am.
When will you decide on the flap coverage? It's a deep wound, the ribs are exposed.
Ma'am, early flap cover is advised in case of electrical burns. So it is better we go for the flap cover within 2 weeks of time after stabilizing the patient.
But
And,
yours may be exposed. You will wait 2 weeks with an exposed pleura.
No, sir.
As early as possible.
As early as possible. The maximum time I mean is before 2 weeks.
So we are telling you already that the ribs are exposed, pleura is injured. So what are you going to do?
Sir,
Why not immediate?
yes, ma'am.
Yes, ma'am. We can go with immediate flap coverage by keeping one. If pleural damage is there, we can go with first intracostal drainage tube placement, and after that we can go with flap coverage by latissimus dorsi. Flap coverage can be done.
Suppose if you have entered inside the OT, done the debridement, you found that the pleura is completely opened up on day 1 itself. What would be your plan?
Place an ICD, drain over the ribs.
Would you do a left dorsal flap straight away to cover the wound? Just put in a
No, sir,
chest tube and wait?
So we can put a chest tube and give a biological dressing in the meanwhile.
Which one? What would you ask for in the OT? What biological dressing? What a shout, na? Give me this.
Sir, in our scenario, collagen is the easiest dressing we get, sir. So that's what we can put.
Good enough. How long do you think the collagen will survive till the assault of electrical contact burns before you can plan a flap?
Hardly 3 to 4 days, sir. By then, we need to come up with the other evaluation and a plan for the flap cover.
Will a lat dorsi be sufficient? Or do you need to repair the pleura also separately and then put a
We
lat
need to
dorsi?
repair the pleura. We need to repair the pleura as well.
How do you plan to do that? Over to Venkat now.
Sir, so can we put a facial cover and
No, I'm asking you right away. You on the table, things have opened up. You said we'll put a collagen dressing. 3 days later, you see the whole thing has been eaten up. Fine, you go for one more debridement, another collagen dressing if needed be. And then again, you see everything has been eaten up, but things have improved. You need to put a flap now. Simply putting a lat dorsi will leave you multiple fistulas here and there.
Yes, sir.
You said fine, something has to be done. Yeah.
We can go with facial coverage for pleural damage, sir, like tensor fascia lata coverage.
And anything else?
Sir, we can go for
one option. Team 1. Next is team 1.
Okay, team 1.
We can go ahead with a mental flap coverage, sir.
How many have you seen being done?
Haven't seen, sir.
Okay.
PFL can be done. Mental or synthetic, we can do PTFE coverage, sir.
Team B.
Sir, we can use rectus fascia as a flap cover over for the pleura, and following which we can use latissimus dorsi to cover the defect.
Okay, imagine that you're exploring. Okay, I'll go back to team C. Since you already originally said that the plan for cover is going to be latissimus dorsi. Given the nature and the site of the wound, okay, you're going inside and seeing that the thoracodorsal vessels also are not really looking great, not really pulsating well. What will be your next plan?
Rectus you can use.
Rectus abdominis flap, sir.
What sort of rectus abdominis? Come on, you guys now should give one final proper answer, you know.
Vertical rectus abdominis flap, sir. Vertical rectus abdominis flap cover.
Yeah, so you should say use such terminologies where you're completely giving the full answer. So what the other team was saying, that they can use a rectus fascia. So here you can get both the flap cover as well
as the flap. Yes, sir. Got it.
The allotted time is almost. Any few final questions, sir?
The left hand, what would you do? First stage? What amputation, what level?
Sir, below elbow amputation, just above the gangrenous level with a proximal fasciotomy and a collagen cover to see the ongoing, if there is any ongoing muscle necrosis.
You are trying to. Collagen cover not required there. You first do amputation, guillotine amputation. Wait for things to improve.
Amputation only, sir.
Above the amputation, I was saying we'll give a fasciotomy and cover that wound with the collagen to see if that is progressing up till the elbow joint, sir.
To see
And
the
the right
progression
side?
of the necrosis.
Right side?
First, we can do fasciotomy, sir. After fasciotomy, if we have to see regularly after 48 hours whether it is necrosing or not. After that, if it is healthy, we can go with grafting, sir. If it is granulating, we can go with
By
grafting.
fasciotomy, you
Probably need a flap cover.
or just fasciotomy, just an incision. Or
Sir?
Sir?
by fasciotomy, you mean just make a fasciotomy cut, or you mean excising the entire wound?
No, sir. Fasciotomy and
Debridement of the surrounding tissues also.
Okay.
Please do not forget that he's losing his left hand. He only has got a right upper limb, which you have
Yes,
to make
sir.
somehow or the other functional. So debride,
Yes.
debride. The hand may become loose if you have
Give an
loose
early flap
tendons
cover.
from there. Sometimes we just pass a K wire to make the hand fixed till we are through with the debridement. Otherwise, you go away and the next thing you see, the slab has broken down and the hand has come down. And then what flap would you put if suppose all these things survive?
Abdominal flap coverage can be done, sir.
You just plan a rectus flap for the
You can't take
how many scars you want to put on the same side, yeah?
Opposite side.
Opposite groin flap, opposite abdominal coverage, sir.
We can go for a free ALT flap also.
No.
Dr. Malti will answer now. Ma'am, please take over.
Bhattacharya sir or PV Sudhakar sir, it's a judge's time.
Please show me the picture. See, the left hand will require a prosthesis, okay, after amputation. Whether you do first guillotine and then followed by subsequent. So, for prosthesis, how do you plan your amputation? Thinking that you have to give a prosthesis later.
We should leave an ideal stump of around 8 to 12 centimeters with a stable cover for the prosthesis to sit in.
Don't give vague answers. What will you do? Stable stump means what? Ideal length means what?
Sir, ideal length of 8 to 12 centimeters, sir.
From where? From where?
From the elbow joint.
Why it is ideal? Suppose 10 centimeter below the elbow. Why it is ideal?
But the process is to sit in it at least, and for the movements, sir, for the distal stump movements, at least 12
Distal
centimeters
stump
we need.
movement. So which muscles will move the distal stump adequately so that the prosthesis is best used? What muscles you expect to be there? Only pronator will be sufficient?
Supinator muscle, sir.
Okay, next question is in this particular patient, how will you prioritize? What are the things you are going to do and when? Sequence of events of surgery. Suppose you have two teams. Suppose you have two teams, one operating on right, one on left. So how will you proceed? Sequence.
Salvaging the right upper limb is the most important since the left has already gone into gangrene. So Early debridement fasciotomy with a flap cover and salvaging the right upper limb takes the priority.
I told you have two teams.
Yes, sir. Upper limb and for the right chest, we would do the debridement and give a temporary coverage with the plan to give a stable flap cover in the second sitting.
You have mentioned about rectus, you have mentioned about lat dorsi. Okay. This is an electrical wound. Adjacent skin is available. You can make two flaps, one proximally based near the shoulder, other distally based towards the flank. Is it safe? Which one is safe? Rectus,
Rectus
lat dorsi,
safe.
just listen. Rectus, lat dorsi, or local flap? Two local flaps. Which one is safe and why?
Rectus.
Why? Why it is safe?
Left leg, right.
Sir, there is chance of involvement of the vessels in the local. So local tissues is not a safer option. And since the
Why?
burnt area
Suppose
is involved,
suppose this is post-infective, then also this stands this answer.
In electrical burns,
Suppose
there
this is
is
a post-infective. Yes, yes.
sir, in electrical burns, there is
in electrical burns, there is chance of involvement of the vessels, sir, and there is more chance of thrombosis of the vessels.
So the local vessels will be involved.
Local vessels we
Okay.
can't take, sir.
Now, if you have to use the rectus, which rectus? Right or
same
left?
side. Right
Same
side,
side.
sir.
Here, the question of involvement of the local vessels are not there. Any other team?
Will not reach, sir.
The right side,
It will not reach. Why it will not reach? In breast reconstruction, what do?
We
You
can
use
take
the
from
same.
opposite
You
side.
use the same side or other side.
Same side.
Opposite.
You can't
side.
use the
Opposite.
other side. Opposite side. So,
We can see.
any other team?
Could you please repeat the question?
Why the local flap is not preferred with the rectus? Lat dorsi you have already answered. Dr. Venkat has mentioned it and you have already given the hint. Okay. So why not a local flap versus rectus abdominis? And if rectus abdominis, why?
There's an inferior supply as well, sir.
Because?
There's an
Sir,
inferior
because
supply.
because umbilicus is the watershed area. So if the flap from the from below, if the opposite side is used, it has less chances of injury as compared to the same side.
Okay, thank you.
No, as sir said, if you can use from the other side as we use for the breast, extend a little bit on the abdominal side. What is the harm? You get a very long flap. Think about it. I would say you in your position, what I would do is maybe debride, put a collagen sheet or a biological film like the costly ones, Polynovo, etc. Then probably apply a whack over it for at least 4 to 5 days. I don't know, none of you answered that. Whack does help in these cases. You get a pretty good wound after 4 or 5 days, you plan your flaps. In the meantime, while you're dissecting, you've been able to see where your feeder vessels are going to be for the flap, as sir said. The lat dorsi chances are pretty poor that you will get a very healthy lat dorsi. But yes, on the opposite side, you should be able to get the rectus along with a modification of DIEP flap so that you can easily cover the wound after the whack has been removed. And I'm saying the word easily, it does happen. But on the left-hand side, I would suggest you may probably, I don't know, the final result, she'll tell you, Dr. Lakshmi, probably it might end up above the elbow. And there are nothing like ideal stump now. You got to save as much as possible. Even if you save 2 inches, there are good things now which can make your hands move also. So as much as possible, and concentrate on the right hand, put a nice good flap, look for a big abdominal flap as low as possible and apply there. If anybody differs from that.
Sir, I have a doubt. Yes, sir. Sir, for example, you said if the pleura is breached, so if we can't apply vac in that at the same sitting, we have to give a facial rectus fascia coverage, or we have to repair the pleura, and then we can apply the vac.
I said give whatever biological cover you have in hand. It could be matriderm, it could be polynovo, it could be a local fascia lata, whatever you feel, apply, put a vac over it, you will never repent. And a good chest tube, of course. On a different side, you will never repent.
Sir, and sir, and for the the question that you asked for the left hand gluten amputation, what coverage you will give? So will it be?
I didn't ask that question. My simple is very simple. First thing is a guillotine. See, after 48 hours, you may have to go higher up, make a big fasciotomy from axilla down to this area. As per the books, open up all the muscles and just leave it like that. Once you feel everything is fine, best possible way is to cover by local tissue itself. Give him a good stump.
Yes.
So local tissue would be the posterior muscle flap that we give now. Posterior flap.
Whatever is surviving, you can't say sitting here. Whatever is surviving. Lakshmi may just tell you the results, ultimate results. There it is. So they could manage to make it into a below elbow. That's pretty good. Normally, when you have a high contact burn like this, you almost 50% chance to end up above elbow. The right hand with the graft only, they have got away.
Lakshmi ma'am?
Yes. So this is the final result. As I told, the left side gluten amputation we have done, and there was a small wound in the axilla also that debrided and closed. And right side fasciotomy and debridement was done and treated conservatively, and granulation developed. So we covered with the graft itself, and he recovered with the good function of the right upper limb. And the left, the chest wall wound, it extended very upward also, the deep muscles also, the pectoralis major, minor, they also necrosed. So repeated debridements, initial debridement on day 2 and the subsequently every alternate day we have done. And there is a necrosis of the obviously seen necrosis of one rib, segmental excision of the rib also done, but there is no pleural breach or the lung involvement. So we managed with the LD flap cover only and with a good result. So this is the final thing.
This is the graph.
Thank
Okay,
you.
sir. Can I move to the second spotter?
Yeah.
I would like to request Umar sir and Praveen sir to lead the questions.
Yeah, what is your diagnosis in this case?
So we can see a post-burn sequelae involving the face, neck, bilateral axillae, bilateral upper limbs, bilateral elbow, and Macaulay grade 4 claw hands bilaterally.
With hypertrophic
scarring over the anterior chest wall.
Okay. During your initial form of resuscitation and treatments, any steps you take to prevent such a postponed outcome?
Yes, sir. By adequate, appropriate positioning and splintage and physiotherapy from the initial.
What is the positioning you give?
So starting from the neck, when there are anterior burns, we need to keep the neck in slight extension.
Of about 15 degrees, we have to keep a neck extension, sir.
And bilateral.
Upper arms should be in abducted position, abducted and slightly flexed position. And the hands should be in position of functional position, that is the MCP wrist extension 30 degrees. Metacarpophalangeal joint should be extended, should be flexed in 70 to 80 degrees. And IP joint should be extended, sir.
Okay, anything else for the hands, upper limbs?
to prevent edema formation, elevation of the
upper limb.
upper limbs.
Okay, why do you don't want edema in the hands and upper limbs? What happens if there is
So,
edema?
Sir, usually in dorsum of the hand, the skin is very loose, sir, and because of that, there is fluid collection will be more at the dorsum of the hand, that is at the level of MCP joint, and there occurs collateral ligaments the shape of the MCP joint is not spherical. Metacarpal head is not spherical at MCP level, sir, and whereas in PIP and IP joint, it is in spherical shape. Based on this shape only, the edema of the dorsum on dorsal side it is more, sir.
because of that,
MCP joint will go into hyperextension. After that, IP joint will go into flexion.
You mean
So
to say
to
any
avoid
hand
this
edema
one,
why is the edema
sir?
will result in stiffness and all? Anything more specific? Is it only bones edema that you're telling, or any edema of the hand, the MCPs will go into a contraction? Any specific? What is it? You can more stress on the fluid,
Actually the collateral ligaments will be
the nature of
because
the
of the
contracted.
fluid. What is
more
it specific?
proteinaceous,
Yes, yes,
the more proteinaceous nature of the fluid.
yes.
That causes collateral ligaments shortens.
Shortening. Okay, so sprintage and elevation, right?
Yes, sir.
Yeah. And what is your
That is in the initial stages, sir. And along with that, we should go for early debridements and cover as well,
order of
rather
treatment?
than leaving it to heal by
Secondary intention, it has to be covered immediately as early as
Early-
possible with skin grafting.
Early resurfacing, you mean?
Early rise.
Yes, sir.
Yeah. So what is your order of management in this case?
Neck.
As the patient is having eversion of the lip, sir, we have to correct postbone contracture of the neck, sir.
So postbone contracture neck release would form the first thing that needs to be released, because it is important
For the nutrition of the
for the
patient,
nutrition of the patient since the lip is everted, and for further surgeries to do for the easier intubation for the further surgeries, we need to release the PBC neck first.
What release? What type of release you want to do?
first we can go with the incisional release, sir, in the neck.
Okay. Any only incision release? You are telling you will correct the ectropion of the lip. So just by incision release, you will able to correct the
No,
ectropion?
sir. Excisional release can also be done, sir. After that, it is followed by grafting.
Okay. What problems you anticipate while before releasing the neck incision from an aesthetic point of view?
The first thing is difficult intubation, sir. So prior to taking up such a patient, we need to get an X-ray done of the neck to see the tracheal positioning. And intubation, if there is a difficult intubation and if they are not able to intubate, we need to give tumescence anesthesia and release the most prominent contracture over the neck to ease the intubation. And after the intubation, we can further proceed with the release of the neck contracture with resurfacing.
What type of
Medium
intubation you are planning?
Sir, fiber optic intubation is preferred, sir.
So fiber optic, they're going to try in this and try to get the anesthesia, right?
Yes,
You're
sir.
planning for fiber optic intubation or directly incision and release and then intubation?
No, sir. No, sir. First, we'll try for fiber optic intubation. But if they are not able, if that is difficult and they are unable to do, we should be ready for the tumescence anesthesia and release.
Any advancement you have over fiber optic to exactly visualize it? Like, yeah.
Video system.
Video laryngoscopy guided intubation, sir.
Yes. And then you would do incision release.
No, sir. Here, since there is a version of lip also, we would need an excisional release with the flap cover. But we have no clue about the donor areas. We can see only the upper half of the body here, and which is completely involved in scarring.
Okay.
So the most prominent bands over the lateral side of the neck, which we see, those can be released.
How early do you plan for this release?
Sir, here it is we need not wait till 1 year, because this is an this is difficulty even for the nutrition, since there is eversion of the lip, and for the neck movements we need to release the PBC neck as early as possible, and the other when the patient arrives.
So how early it can be released? You have a neck contracture.
First, we have to see the scar should be matured, sir. In the neck, at least the scar can be immature also to
6
release.
months.
Even if the scar is immature also, we can release in the.
Because there is severe neck contracture here.
How will you know whether the scar is mature or immature?
Scar maturity we can see by elevation. It will be like flat, sir.
The mature scar is
will be flat, and there will not be any blanching, and the vascularity will be reduced.
No pruritus.
No pruritus.
What is a contracture?
It will be soft, sir.
What
So
is a
contracture
contracture?
is any scar which reduces the range of movement over a joint.
Is it flat?
No, sir. Abnormal contracture, it's not flat. It can be either in the form of a band or a broad scar.
So last 2 minutes for discussion.
Okay. Then next, what is the apron? How do you manage the hand?
So hand, usually we progress from proximal to distal, but here both the hands are severely in the Macaulay grade 4, which is severe functional disturbance to the patient. So we can correct the claw hands first, but we should go one after the another. So we need to ask the patient which she would like to get operated
We have
first,
to
and
ask
the
the
functional
patient
dominant hand needs to be operated first.
Okay. You maintain this pintouch with K-wires or anything?
So
we will maintain with K-wires, sir.
Do you think the volar side or flexor surface or wrist also is involved from the picture, or it is free?
I think it is free, sir.
Okay.
Polar side of the palmar side.
Yeah. Okay. Dr. Farooq is there?
Yeah.
Yes. Please.
What will you do for this neck and face?
Sir? The neck excisional release with resurfacing with an intermediate thickness graft.
Neck and face. Are you hearing me?
Sir?
Neck and face.
Yes,
How
sir.
will you manage neck and face?
Sir, for the neck excisional release of the scar with intermediate thickness graft.
And?
With a cervical collar, sir.
If you see, what can you see in the lower face and the neck?
There is contractured bands are extending from the lower
lip to the anterior chest wall near the clavicle.
What about the oral cavity? What can you see there?
Sir, we can see that the lower lip is everted, sir.
What is that called?
Sir, it could be most probably a secondary contracture also. So first we will release the neck contracture and see.
That will be corrected, sir, by releasing this neck contracture.
The eversion of the lip is due to what? Picture
contracture.
Yes.
It is due to the contractures.
There is hypertrophic scar also.
Contracture. What is
Sir, I said that it could be due to the extrinsic contracture, so I wanted to release the neck contracture first.
Do you think so? Where is the chin?
Sir?
Can you see the chin here?
Sir, in this picture, I'm not able to clearly make out if the chin is totally touching the sternum or it is slightly free.
I
I
agreed
presume that it is
that
slightly free.
neck takes the priority over all the contractions. Right?
Yes, sir.
Agreed. Then what about the other contraction? Can't you release with the neck, eversion of the lip, release the chin,
Yes, sir.
make a proper chin?
Yes, sir, definitely.
He means a lower lip
Then how can you do?
ectropion.
Can you
Yes,
see
sir.
ectropion here? You can see
Yes,
the
sir.
gingiva. You can see the gingiva, lower gingiva as well. So
Yes, sir.
you have to correct that. There must be the drooling. There will be the problems with the eversion of the lip, ectropion, right? So
Yes,
you
sir.
have to address that also.
Okay, sir.
Got it?
Yes, sir.
Time is over, sir. Now we'll move to moderator sessions.
See, I would love to place one nice, good, broad skin graft from the ectropion down to the neck. If the thighs are there, thighs are spared by the burns. If you could do that, the rest of the job becomes
You can
much
keep the
easier.
picture there on.
Yeah, keep the picture on, yeah, please.
It
Yeah,
makes the
Rohit.
things easier.
Okay, sir. 1
You
minute.
keep the picture there.
Then probably one hand completely in one single stage. Right or the left, the both are equally damaged. So the axilla, as well as the elbow, as well as the wrist. You could leave the fingers behind for the next stage if you want.
Yes, sir.
The gone are the days where you say we don't have enough graft. No, we have enough graft these days. You can take out as much as 10-12% also and apply the graft in the first sitting. And then she comes back for the second sitting. You can do the fingers or do the other hand, whatever is feasible. And I believe the wrist again is pretty badly dislocated here.
Yes, sir.
So we haven't seen the skin on the ventral side. Probably it will also require a flap once you open up the everything. That's all. Let's see what Dr. Lakshmi has had post-op.
1 minute, sir.
Sir, actually, this is shared by Dr. Neela Bhattacharya from Siliguri. So if she can join, we will invite.
She's there.
But
She's there. I
it
just saw her.
Dr. Neela, kindly unmute yourself and explain what is done for this case by you.
Yeah, good evening.
Yeah, good evening.
No, I just, this lady came with such a severe contracture. She is from a nearby place, and because of the absence of any plastic surgeon, she did not have relief of any of the contractures. She was living with this like this for about 7-8 years when she came to us. We did the neck first, as it was told. We did the neck and the lip in a single graft. Dr. Sinha, you were talking about long grafts. Yes, from the cheek, from the chin to the neck, there were 3 long grafts which were put. And that has settled that. That was the first stage that we did. After we got the neck into some shape, only then we were able to do the other surgeries. So as a second stage, we did both the axillae. She had people who could look after her, feed her, etc. So we were able to put both hands into splints and did both the axillae and then the right wrist was released and grafted. Dorsal set. She would need a volar. She would need a flap on the other side actually, but we released the wrist a little and grafted. And after that, but the patient did not come back for further. She said, "I'm able to move this hand. I'm able to do work. I'm not going to come back for further surgeries." So this was the situation in which we left her with the neck release, with both axillae free and both elbows free, and a right wrist which was corrected with dorsal graft.
Very nice, Neela. Wonderful chin and lip correction, and remaining also acceptably, functionally Feasible.
Yes.
That's
Economics becomes the factor here, no? When they come for
Yeah,
repeated,
That's
so
correct.
that becomes.
I think she might have not used
That
it
is the reason the
prospectively.
maximum you can
Collar
give in a
also.
single sitting. That is the important.
She didn't use.
So whatever maximum reconstruction we can do in a single stage, that is
Yeah,
important.
that is the best to be done for her. Yes,
That is the best,
exactly.
because these patients
Because
don't turn up later on.
they will not come. So once she had some people looking after her, we did both the elbows, both things, and the right.
Yeah.
Wonderful.
Okay. Thank you so much.
Limited stages, maximum done.
Yeah.
Good.
Thank you.
Thank you, Dr. Neela. That was wonderful.
But today
Lovely
all
presentation.
the spotters over. I invite the judges. Sir, Bhattacharya sir, have you told anything for the last spotter?
Only thing is that I wanted to ask the candidates. Everybody is talking about K-wire fixation of after release. How do you do K-wire fixation? Where you enter, and when do you think that it is adequate? And what is the exact procedure of K-wire fixation? It's easily said than done. Yes.
Team C.
So in the finger K-wire, we have to put first stab incision with the 11 number blade, reach the bone, and then we have to touch the K-wire to the distal phalanx distal point, and then we have to straightening the fingers and slightly traction of the fingers, and then we have to pass the K-wires. And
why
then
you have to make why you have to make an incision to feel the bone?
Sir, in the passing the fingers K-wires, they might be injured the nail plate and might go to the pulp area of the
Why?
fingertip.
Then my next question then will be, where will you enter of that phalanx? How do you avoid the nail bed? That's what I'm exactly asking. It is easily said than done. You have made an incision. Now that incision will allow you to do what? Will it allow you to
reach
see,
the K-wire.
will it allow you to see the distal end of the phalanx?
Sir, to feel the K-wire tip to distal end
To
of
feel the
bone.
nail bed from below.
Nail bed.
Even otherwise you can do it without making an incision.
Whatever you are doing practically in your department, you are doing that is right. We are never doing anything wrong. What you are doing practically when you operate, that is the answer.
Anyway, how do you progress? How do you proceed? You have engaged it distally.
Then the passing the K-wire with the
drill machine.
Drill machines.
What do you tell your assistant?
What is the assistant doing that time?
At the time, stabilize the wrist and slightly counter traction.
How do you feel satisfied that he has stabilized? Otherwise, again you have to pull it out. Again you have to get it in. When you are satisfied as a surgeon that he has done adequate stabilization.
No movement at the joint. There's no movement. He's
proper alignment is there. We have to look for proper
See,
alignment.
suppose you are doing a hand drill, as you said. Then you keep on moving it, and he stabilizes it. Now, how do you feel satisfied that you have crossed one joint, then to the next joint? When you are going to stop? How much K-wire has gone in?
So we can simply compare it with another K-wire length.
Okay. For length that is okay. Then up to which joint you will go in this case? Is there any easier method so that you can take the advantage of latest technology and do it more easily?
CM technology.
Okay, so if you don't have CM, whatever you are telling, then when will you stop? At what level will you stop? How many joints you will cross? How many joints you will cross to stabilize the fingers?
2 joints, proximal and 1 distal.
One proximal, one distal.
Tell me, don't give vague answer. PIP,
So we have
DIP,
to come
MP,
till
like that.
MCP joint.
The
MCP
MCP
joint.
Okay, so how much beyond MCP joint you will stop? Where will you stop? How
Just
much
distal to the
proximal to MCP joint?
We will clinically assess to. We'll just
Beyond-
we'll
What
clinically
is the
assess till the
what is the
MCPJ is
principle of K-wire fixation? That's what I'm asking. Where will you stop? How much proximal to the MP joint?
Beyond the head of the MP, sir.
No.
So
Then
just
you-
when the MCPJ is immobilized in the extension, that's it.
So you will go at least 1.5 centimeter to 2 centimeter proximal to the MP joint. Okay. Now somebody said about cervical collar. Now you are putting a graft, large graft, as Dr. Sinha has said, and you have quilted nicely in the configuration. Now, when will you use cervical collar? You said, somebody said cervical collar. Immediately during surgery or immediately after first dressing?
Sir,
When
after first dressing.
And then the whole graft will get erased in that cervical area.
Sir, we need to wait for 2 weeks for the graft to settle, and then we
After
start.
remodeling of the all staples and everything, we need to start the collar, sir.
Third thing is,
In the meanwhile, we give a adequate dressing so that the neck is an extension.
yeah, and all the time he or she is not wearing the collar. In the intervening phase, what do you advise the patient?
To see that the neck is an extension.
How?
So by keeping a towel rolled just below the shoulder blades.
Bolster can be kept over the shoulders.
Not feasible.
No.
Not feasible. Very difficult to do that.
Very difficult, exactly.
Just tell them no pillows. That's about
At
all.
least no
Yeah.
pillow.
Not to use
It's
pillows,
not
sir.
a towel.
And see, towel is not the answer.
Not to use
Okay.
pillows, sir.
Bolster.
No pillow at
Pillow
least
should not be used
below the head.
And the third thing is that why don't you do neck, axilla, elbow simultaneously?
Sir, if
You
you do
should not do. I'm telling you, should not do. Ideally, you can do what we can do. We need not do always. Okay, we can do, but why not?
If we do the neck and axilla, sir, we cannot maintain the position, sir, because if we do the axilla, we need to keep the arm in abduction. So, but the neck will get flexed, so we cannot maintain the position of the neck and extension.
Yes. Any other reason?
Post-op physiotherapy is difficult.
Post-op physiotherapy.
Yes. Physiotherapy is always painful. And
Yes,
if
sir.
there is no adequate person with the patient to do physiotherapy, they will inadequately do all of them, and therefore there will be recurrence. So get one joint nicely done, then go for the next adjacent joints. That's the way. That's more practical.